Very good morning, ladies and gentlemen. Welcome to another web series, and I think it is timely to revisit the management of COVID 19 in pregnancy. Ladies and gentlemen, I would like to dedicate this talk to the 144 mothers in Malaysia and the 64,000 over mothers who have died worldwide due to COVID 19. And I believe that as an obstetrician, I believe in one mantra that no woman should die while bringing life into the world. Hence, it is extremely important that we do our level best to reduce maternal mortality, especially from COVID 19. Ladies and gentlemen, I've got two conflicts of interest. I have been involved in the development of two guidelines with regards to COVID, the guidelines on vaccination among pregnant mothers, the MOH guidelines on management of COVID 19 in pregnancy, but otherwise, I've got no other conflict of interest. In the next 30 minutes, ladies and gentlemen, I would like to highlight the implications of COVID in pregnancy, certain specific considerations that we should focus on. The maternal and fetal steroids, what are the difference? An update on thromboprophylaxis, safety of medications, the prone position in a pregnant mother, when to deliver, pre-delivery considerations, the implications of long COVID-19, an update of perinatal mental health, and briefly, finally, some key points with regards to pregnant frontliners and some update about vaccination in pregnancy. And this is the overview of my talk, ladies and gentlemen. Ladies and gentlemen, what are the implications of COVID-19 in pregnancy? Let us revisit that even since day one from COVID-19, we do know that pregnant mothers are susceptible to infections, namely viral infections, especially in the late second trimester and the third trimester. And this experience can be extrapolated from our experience from managing influenza patients, varicella patients, malaria patients, and hence we perceived that COVID-19 might have similar implications. However, ladies and gentlemen, I think we were actually swayed by the initial studies from Wuhan. The initial studies from Wuhan did not paint a similar picture because they showed that 92% of mothers were asymptomatic. Further publications early in the day with regards to COVID-19 showed that the implications on pregnant mothers is not as dramatic. But ladies and gentlemen, I believe these were early days, but the implications is far greater than what we perceived in the early days. I would like to highlight one important systemic analysis, which is called the Living Systematic Review and Meta-analysis. This is a wonderful paper from the BMJ, which is regularly updated. And this paper has reviewed 64,676 pregnant mothers, 569,981 non-pregnant mothers, and it's a wonderful living systematic review and analysis, looking into the implications of COVID-19 among pregnant mothers. So ladies and gentlemen, based on this systematic review, if you are pregnant and you are COVID-19 positive, the maternal mortality is increased, ICU admissions are increased, the incidence of stillbirth and prematurity is increased, neonatal deaths is increased, and ICU admissions are increased, namely due to the prematurity, and the incidence of fetal heart rate abnormalities and fetal distresses are increased. The most recent update was a few months ago in 2021. Now let's take a look at various other papers as well. I would like to bring your attention to this paper from Asma Khalil, also a systematic review and meta-analysis of clinical features and pregnancy outcomes. And similarly, they reported that if a pregnant mother gets COVID-19, her need for oxygen support is increased, her need for mechanical ventilation is increased, cesarean section, preterm deliveries, and fetal distresses are increased. Ladies and gentlemen, there's also a pregnancy COVID-19 registry from the University of Birmingham. It is what I believe is one of the largest registry of pregnant mothers with COVID-19. And based on this paper, if a pregnant mother has got COVID-19, the incidence of preterm delivery is increased. The incidence of stillbirth is increased in the acute phase. Similarly, ladies and gentlemen, various other publications from the United Kingdom to the United States of America showed a similar picture. Various other countries all showed an increase in maternal mortality, an increase in maternal implications, an increase in preterm delivery. So with that, ladies and gentlemen, which was the most significant impact? Was it the first wave or was it the second wave? I would like to bring your attention to the ICNAC report, which looked into admissions of mothers to the critical care unit. And it is quite clear that admissions following the second wave was far higher and was far more significant than the first wave. Similarly, ladies and gentlemen, there were no maternal deaths in Malaysia in the first wave. But up to now, there were already 144 maternal deaths in Malaysia in the second wave. So that shows perhaps it is related to the newer strain, to the Delta strain. So ladies and gentlemen, we can summarize that the incidence of admission to ICU, if someone were to have an alpha variant, is 1 in 10. But if a pregnant mother was to have a Delta variant, the incidence of admission to ICU is 1 in 7. It is interesting to take a look at these characteristics because we do know now that the newer strains have got far greater implications in younger adults as compared to the incidents last year, where our main concern were the elderly, were the vulnerable group. So ladies and gentlemen, various other papers also showed similar events, that pregnant mothers were more susceptible in the second wave. Pregnant mothers had got far greater implications due to variants of concern, namely the Delta variant. So with that, I can conclude, ladies and gentlemen, that most mothers will be asymptomatic. Almost 2/3 of them will be asymptomatic. However, they are vulnerable, especially in the late second trimester and the third trimester. The incidence of ICU admission can be increased as 1 in 7 if one to have a Delta variant infection. The second wave of COVID that we witnessed throughout the world and in Malaysia has got far greater pregnancy implications. If a pregnant mother has got COVID, she's got increased incidence of ICU admissions. There's an increase in need for ventilation. Maternal mortality is increased. There's an increase in need for iatrogenic preterm deliveries, neonatal ICU admissions. There's an increase in cesarean sections, and there's also an increase in stillbirths and neonatal deaths. And this evidence is true across the world, across the countries, and even in Malaysia. So ladies and gentlemen, having understand and appreciating this fact, what are the specific considerations during pregnancy that we should highlight? I think we should differentiate mothers who need outpatient and inpatient care. Who needs inpatient care? Mothers with moderate to severe symptoms. Pregnant mothers with comorbidities, BMI of above 30, age above 40, mothers with diabetes, mothers with cardiac diseases. We do know that gestation plays a significant role. So perhaps mothers in the late second trimester and third trimester should be managed as inpatient, and mothers who have got persistent temperatures despite conservative measures, mothers with secondary hemophagocytic lymphocytosis, or mothers with cytokine storm are the cohort of groups that should ideally be managed in the hospital. So ladies and gentlemen, we should perhaps, based on our resources, have a very strict criteria of who should be managed as outpatient, who should be managed for inpatient. But please appreciate the fact that pregnant mothers are vulnerable. So I believe it is okay to manage low-risk mothers early in the pregnancy, provided we have got strict criteria and there should be a safety net on when and how they should assess healthcare. Perhaps the way forward, we should have a dedicated low-risk quarantine centers for pregnant mothers with specific guidelines so that care can be escalated if required. So, ladies and gentlemen, what are the key features with regards to oxygen saturations in pregnancy? I believe it has been controversial, but it's worth revisiting. Now, the oxygen saturation, if it's non-pregnant, the acceptable level is 92%. However, if you're pregnant, it should be 95%, ladies and gentlemen. It is not only important to monitor oxygen saturations, but also important to monitor the need for supplemental oxygen requirements. It should not be oxygen saturations at rest, but it should be exertional oxygen saturation. So ask the mother to walk for 6 minutes, check for oxygen saturations, and exertional saturation is far more important than a saturation at rest. It's also important to assess her breathing efforts. Does she have labored breathing? Does she need to use accessory muscles? These are key clinical features which is important. And finally, prior to discharge, if she has completed her 10 mandatory days of quarantine, check an exertional oxygen saturation prior to discharge. So what are the specific considerations, ladies and gentlemen? I believe pregnancy, you need a far bigger, a far more comprehensive multidisciplinary team, and this should include a senior obstetrician, a maternal fetal medicine specialist, and a neonatologist. So these mothers should be admitted to units where you do have neonatal facilities. It is important to make a shared decision making. It is important to involve the obstetricians early in the management of care of the patient, because based on the Malaysian Confidential Inquiry of Deaths, we realize that these mothers lacked multidisciplinary care, the obstetrician was not involved, and they were managed purely by a specific team. So I would like to highlight that multidisciplinary subspecialized team is essential in managing of COVID-19 pregnant mothers. Apart from that, it is important to monitor the fetus, not just the mother, because the incidence of fetal distress and stillbirth is high. Ladies and gentlemen, I'd like to highlight one key fact. No COVID-19 treatment or intervention is contraindicated in pregnancy, and neither should it be withheld purely in the name of pregnancy. Imaging is safe. Medications are generally not contraindicated in pregnancy and in breastfeeding, because the placental transfer of medications are far more significant than the amount of medications transferred via the breast milk. Consider thromboprophylaxis. There's only a few selected criteria for delivery. It should purely be for obstetric indications, not maternal indications, and you need to have certain pre-delivery optimizations. So, ladies and gentlemen, having understood that, I would like to highlight one important slide. If you're going to remember this presentation, please remember this slide. I believe we need a change in mindset on how we manage pregnant mothers. We should appreciate that the mother is not a vessel that carries the baby. The mother's life is far more precious and should be the main priority. Medicine has often been too fetal-centric antenatally, but on the other hand, it has been too maternal-centric postpartum. Why do I say we have been too fetal-centric? We often think about the fetus, we forget about the mother, and the interventions and treatments may not be optimal. And I believe this is substandard care. It is important that essential interventions are not withheld. It is because it does not cause harm, but I believe it is often withheld due to ignorance. So, ladies and gentlemen, no medications or interventions is ever contraindicated in pregnancy most of the time. Now, I also like to highlight one final point, that ventilation does not equate to delivery. There's only one criteria to deliver a pregnant mother. It is for obstetric indications. So having known that, how do we manage COVID-19 pregnancy? Most patients are asymptomatic, 2/3 of them. Inpatient management is recommended, especially if they are at risk, especially at a later gestation. Please remember, exertional oxygen saturations, lactates are important. Monitor the respiratory rate. It should not be above 25, not 30, above 25. Monitor the renal function, the urine output, and the GCS. The mother's COVID positive, she needs prophylactic dose of low molecular weight heparin. There has been some controversies about vitamin D and vitamin C, but some papers do show that it is beneficial. Maintain hydration, ensure the mother has got a neutral balance, and do not abuse antibiotics unless really indicated. Ladies and gentlemen, imaging is not contraindicated, and X-ray is safe, a CTPA is safe, a high-resolution CT scans are safe. If the team thinks the mother needs this imaging, please proceed with one. If it's life-saving, it is not contraindicated. If the mother requires oxygenation, if the mother is hypoxic, it is important to rule out an embolism. It is important to rule out a myocardial injury. Now, please remember, ladies and gentlemen, there's no role for D-dimers in pregnancy. Please do not prognosticate VTE based on D-dimers. What is important, you need an objective assessment of pulmonary embolism. This should ideally be a Doppler of the lower limb or a CTP. Prednisolone is safe. Hydrocortisone is safe based on the recovery trial. We also know that Tocilizumab and monoclonal antibodies are not contraindicated in pregnancy. The mother's ventilated in ICU, prone positioning of pregnant mothers, it's okay. You don't really have to prophylactically deliver a pregnant mother just to turn her prone. ECMO is not contraindicated. And ladies and gentlemen, delivery, apart from obstetric indications, can be reserved for patients with refractory hypoxemia. So what are the red flags in pregnancy? 5 red flags. Respiratory rate of above 25 breaths per minute, an increase in oxygen requirements, a reduction in urine output, acute kidney injury, and drowsiness are the 5 red flags among pregnant mothers. And this indicates that you have to escalate treatment. So ladies and gentlemen, can you ask a pregnant mother to exercise? Yes. Please remember, an exertional test, an exertional SpO2, and an exertional heart rate is far more important than an oxygen saturation at rest. Based on the ACOG guidelines and the NICE guidelines, 30 minutes of regular to moderate intensity exercises are safe in pregnancy, but what we are recommending is a 6-minute walk test. There are certain absolute contraindications for exercise in pregnancy, and they are hemodynamically significant heart conditions, an insufficient cervix, multiple gestations, placenta previa, which is bleeding, but otherwise there are no other absolute contraindications to stress a mother or to exert a mother in pregnancy. So ladies and gentlemen, let's talk about mode of delivery. Although the Malaysian guidelines does recommend cesarean section, that is purely based on resources, that is purely based on the fact to protect the staff. But we should appreciate one fact, that vaginal delivery is not contraindicated among COVID-positive mothers, and vaginal delivery is not an aerosol generating procedure. There's no benefits of routine shortening the second stage. If you do have facilities, if you do have an isolated, a negative pressure labor room, this is perhaps the way forward to deliver mothers with COVID-19 vaginally, provided you do have a clean labor room and a COVID-dedicated labor room. The patient should wear a double mask, a face shield. The staff should wear a PPE, but vaginal delivery is not an aerosol generating procedure. Vertical transmission for the mother to the baby is rare, and breastfeeding is not contraindicated, although there's a risk of direct transmission via contact. So ladies and gentlemen, let's revisit the guidelines on acute COVID-19 in pregnancy from the RCOG. So they wonderfully highlighted certain principles, namely antibiotics unless there's a clinical suspicion of bacterial infection. Low molecular weight heparin is important. Steroids, especially 2 types of steroids, oral prednisolone 40 milligrams or IV hydrocortisone 80 milligrams BD. But if the mother is on prednisolone or hydrocortisone, the baby needs dexamethasone for lung maturity. It's important to have a multidisciplinary team. If the mother's CRP is above 75, consider Tocilizumab, and the most recent guidelines based on the Region COF trial consider strongly the need for monoclonal antibodies, especially if they have got no SARS-CoV-2 antibodies. So, ladies and gentlemen, it's important to manage and have an algorithm. It's important to risk stratify them into green, into yellow, into amber, and into red. And please remember the 5 red flags in pregnancy, namely a drop in oxygen saturation, an increase in FiO2, and the importance of initiating steroids timely based on the recovery trial. So moving forward, ladies and gentlemen, I would like to highlight that radiation is safe in pregnancy. It is not contraindicated. So the number to remember is 50 milligauss. If the mother has got an exposure of below 50 milligauss, irrespective of the gestation, there's no fetal harm. And ladies and gentlemen, the radiation from a high resolution CT scan is 1.6. So theoretically, you can do 40 high resolution CT scans in pregnancy before you reach the toxic dose. So radiation is not contraindicated. How about steroids and placental transfer? 2 steroids have got very low placental transfer, namely hydrocortisone and prednisolone, while 3 other types of steroids, methylpred, dexamethasone, and betamethasone, have got significant placental transfers. So if the mother is on hydrocort, if the mother is on prednisolone, if you are considering deliver prematurely, the baby needs IV dexamethasone, 6 milligrams BD for 2 days, and that will be optimal for the fetus. How about Tocilizumab in pregnancy? Ladies and gentlemen, there's increasing evidence based on the experience of using Tocilizumab among rheumatoid arthritis patients in pregnancy that it is safe, it is not contraindicated. If you think the CRP is above 75, you should be initiating pregnant mothers on this. How about Baricitinib? I must be honest that there is lack of evidence with regards to Baricitinib in pregnancy, but there's increasing evidence that it is not contraindicated. It's always a balance between benefit and risk. If you think it is important to save the mother's life, I think it is okay to administer Baricitinib, provided you have counseled the family. Ladies and gentlemen, there's increasing evidence about the importance and the benefits of monoclonal antibodies. And the RCOG Green Top Guidelines does recommend monoclonal antibodies for pregnant mothers. There's no robust pregnancy data. It is currently being evaluated in the recovery trial in pregnancy. But so far, based on the physiological understanding that it is unique to viral proteins, we can extrapolate that it's unlikely to affect fetal development. There have already been 25 mothers with this exposure who showed no adverse fetal effects. Use this if you think it is beneficial. So moving forward, ladies and gentlemen, based on various medications for COVID-19 pregnancy, I would like to highlight your attention to 2 important resources. One is the UKTIS, known as the UK Teratology Information Services. They've got a wonderful guideline about medications to be used in pregnancy. It's a wonderful resource. Please use this resource as compared to FDA, which is a guideline based on risk, not a guideline based on benefit. So please use UKTIS, or you can also use BUMS about best use of medicines in pregnancy. So moving forward, ladies and gentlemen, let's talk about a more controversial topic about venous thromboembolism. So we do know that all COVID positive mothers in pregnancy, if they are suspected or confirmed, they should ideally be on prophylactic doses of low molecular weight heparin. We also do know that despite being on prophylaxis, almost 1 in 3 of them may have arterial or venous thrombosis. So it's important to have a high index of suspicion, especially if the patient is tachycardic, especially if the patient desaturates, especially if the patient does not recover despite conventional therapies. You need an objective confirmation. Please do not rely purely on D-dimers in pregnancy. So ladies and gentlemen, the evidence is clear. If you have a pregnant mother who's COVID positive, start her on prophylaxis. But for some other reasons, if you're unable to exclude a thrombosis, it is okay to start her on treatment dose of low molecular weight heparin. But think of thrombosis. Have an objective assessment, either a CTPA or a Doppler of the lower limb. If you have negated a thrombosis, then you can reduce her for prophylactic dose. The duration is controversial, minimum 10 days following the discharge, but in certain high-risk group of patients, you can extend this for a period of 3 weeks following discharge. So ladies and gentlemen, let's next move on to the prone position. I believe there are evidence with regards to the safety and the importance of turning a patient with ARDS to the prone position. So just for the sake of turning someone to the prone position, you don't really need to deliver someone. It is safe to turn a pregnant mother beyond 24 weeks to the prone position without delivery. All you need is 4 pillows, 1 pillow on the head, 1 pillow on the chest, 1 pillow on the pelvis, and the 4th pillow below the knees, and you can safely turn the mother to the prone position. On the other hand, if the mother is ventilated, she can also be turned into a prone position without the need for delivery. Because, ladies and gentlemen, it is a complex decision that should be made following a shared decision between the intensivist, the obstetrician, the neonatologist, having a multidisciplinary team approach. So finally, with regards to patients who have got refractory hypoxemia, if you think you have escalated the intensive care, if you think you have used every single airway adjunct, if the mother's already on ECMO, then it is perhaps okay to consider a delivery, but a delivery should not be considered in the first instance. So ladies and gentlemen, when to deliver a pregnant mother, I believe there are 3 clear indications. 1 should be for obstetric indications. 2, mothers with refractory hypoxemia. And 3rd, in the event where the mother collapses. So mechanical ventilation alone is not an indication for delivery, but please consider other advanced methods prior to delivery. There are a few things that you can do prior to delivery to optimize the fetus. 1, if the mother is on prednisolone or hydrocortisone, consider dexamethasone 6 milligrams BD for 2 days. If the fetus is below 31 weeks and 6 days, consider magnesium sulfate for at least 4 hours before delivery. The mother is on prophylactic doses of low molecular weight heparin, delay for at least 12 hours, treatment dose 24 hours. But please be worried that the delivery should be undertaken by the senior most personnel, because the incidence of platelet dysfunction can be significant. The patient may have clinical coagulopathy, which has been documented. So adequate hemostasis based on clinical criteria should be important. Be careful with the use of tranexamic acid. You can use it therapeutically, but not prophylactically. And the mother is on treatment dose of low molecular weight heparin, you can use protamine sulfate to reverse the effects of low molecular weight heparin. Consider intraperitoneal drains, mainly because of the incidence of coagulopathy. So ladies and gentlemen, traditionally we have used unfractionated heparin because we thought that they can be reversed with protamine sulfate, but now we do know that despite patients being on treatment doses of low molecular weight heparin, you can use protamine sulfate, which is efficacious for almost 60% of the time. So moving forward, ladies and gentlemen, we traditionally used to use the term of perimortem cesarean section. But in the modern world of obstetrics, we have moved away for perimortem cesarean section. Do not deliver when the mother has got perimortem, but deliver as part of a resuscitation. And now it's called a resuscitative hysterotomy. So it's important to have these two when you have and when you are managing any COVID-19 mothers. This tool can be made available in the wards, in the ED, in the ICUs, and all you need are 6 essential criteria. You need a disposable antiseptic, you need a scalpel, a needle holder, a blade, a suture, and you make a midline incision, do a classical cesarean section, deliver the baby, close the uterus with one layer, and this is known as resuscitative hysterectomy. So, ladies and gentlemen, how do you manage patients who have had survived? It's important to ensure that they have a specialist review, ideally a family medicine specialist or an obstetrician. It's important to review them as early as 10 to 14 days. Think about venous thromboembolism that may manifest later. Think about organizing pneumonia. Think about the implications of long COVID. In where I work, within my maternal medicine clinic, I have initiated a dedicated post-COVID-19 obstetric clinic, and the learning experience is very enriching. So think about venous thromboembolism. Consider prophylaxis for a minimum of 10 days post-discharge, can extend up to 21 days in significant patients with complications. The patient is on treatment dose where you have an objective confirmation of VTE. The treatment should be for at least 3 months from the diagnosis of embolism, not 6 weeks, but 3 months, whichever happens later. Now, fetal implications, stillbirths and fetal distress is during the acute event, but the long-term implications, there are some documented incidents of increase of SGA. So these pregnant mothers having survived COVID-19 need 4 weekly ultrasound scans to detect SGA. There are, however, no congenital abnormalities. And ladies and gentlemen, having recovered from COVID-19, these pregnant mothers can deliver vaginally, even if they are on oxygen therapy, even if they had a thrombosis, even if they have long COVID. There are no contraindications for vaginal delivery. So how do you manage long COVID syndrome in pregnancy? I think before someone embarks on a pregnancy, a 6-minute walk test is important. If she's still symptomatic, refer to the respiratory physician. A baseline X-ray or a lung function test is important. If she's still breathless, look at long-term implications of myocarditis. You need to assess the cardiac function. She may benefit from an ECG and echo. Please ensure she's got a baseline normal renal function, that she has recovered from the renal implications of COVID-19. A baseline renal function, a baseline urine PCR will be important. Please ensure she has recovered from an embolism. If she's on treatment dose, she needs to continue this in the pregnancy. If she had a previous COVID-19 infection, if it's provoked, she may need prophylaxis in this current pregnancy. Address the fatigue, the low mood, the depression. It's important to review the medications, steroids, antibiotics, rehabilitation, a multidisciplinary team. And this will be the outline of management of long COVID-19 patients in pre-pregnancy. So ladies and gentlemen, having appreciated the physical implications, let's not forget the mental health. What are the 5 red flags of perinatal mental health? Be concerned and escalate treatment if there's a sudden change in the mental state of the mother, if there's new symptoms, if the mother gives acts or thoughts about self-harm, if the mother expresses incompetency as a mother, and there's estrangement from the child, these are 5 red flags that you should routinely ask, check for, and escalate treatment if any one of them is present. What about policies for pregnant mothers? Ladies and gentlemen, I think as a fraternity, it is important that we protect our vulnerable. It's important that we protect our frontliners. It is important to ensure that they have completed their vaccinations. I think moving forward, people are already talking about booster dose for at least beyond 6 months for high-risk group of patients, including health caregivers. It's important that if possible, we avoid direct or high-risk exposure for any frontliner who's pregnant beyond 22 weeks, if it's feasible. How about an update about vaccination in pregnancy? Ladies and gentlemen, we do know that mRNA vaccinations are safe, but how safe are they in the first trimester? This wonderful paper we just published just a few weeks ago looks into the incidence of miscarriages for those who have been vaccinated as compared to the general list. Now, at every gestation, from 6 weeks to 20 weeks, the vaccination does not cause an increased risk of miscarriage as compared to the general population. And this strengthens the fact that COVID vaccination is safe even in the first trimester, it does not cause miscarriage. So, ladies and gentlemen, I'm going to share some 3 important clinical vignettes that I encountered in my own clinical practice. 2 weeks post category 5 COVID infection, a pregnant mother presents with fever. We thought that she had long COVID syndrome. We did a CT scan. We thought she perhaps had a thrombosis. We did a CTPA. But do you finally know what she had? Her platelet counts start to drop. Her white cell counts start to drop. Her liver function was deranged. She had dengue fever. So, ladies and gentlemen, please do not be COVID-centric. Although you should think of the long-term implications of COVID, please think of other common infections, namely dengue, which is prevalent in Malaysia. Clinical vignette number 2, a known asthmatic mother, COVID category 2, presents with tachycardia on exertion. Now, she never had an imaging in pregnancy, but because her tachycardia was significant, even on exertion and even at rest, we did a CTPA and realized that she actually had an undiagnosed pulmonary embolism. So, ladies and gentlemen, don't just think that tachycardia is normal in pregnancy. If the mother complains of a symptom, it should be addressed appropriately. Clinical vignette number 3, a pregnant mother has already had the diagnosis of embolism. She's already on treatment dose of low molecular weight heparin, presents with persistent tachycardia and shortness of breath. What do you think we should be doing, ladies and gentlemen? We did a chest X-ray. The chest X-ray was clear. We contemplated on the need for a high-resolution CT scan. But because she had an embolism, we wanted to ensure that the treatment dose of a low molecular weight heparin was adequate. And so we checked an anti-10A level, and we realized that anti-10A levels was way below the therapeutic level. So, ladies and gentlemen, if the patient does not get well, the patient is on treatment dose of low molecular weight heparin and still has persistent symptoms, monitoring of anti-10A levels in pregnancy can perhaps be an option if feasible. And so we increased her medications and she got better. So with that, ladies and gentlemen, I just recently saw 2 days ago a pregnant mother who has got 2 infections of COVID-19 in her pregnancy. One at 5 weeks when a CT ratio was 30, and another 6 weeks later at 14 weeks of pregnancy, the CT ratio was 12. And I believe you'll be seeing more and more patients, not with 1 infection, but have survived 2 infections. So, ladies and gentlemen, having appreciated that, please do not be too COVID-centric. Please remember, viral infection is the most common cause of infection. Be holistic in your approach. Do not forget dengue. Do not forget other causes of fever. So what is the future, ladies and gentlemen? I believe we should need a pregnancy COVID-19 registry. And this has wonderfully been started by the University of Birmingham, where they now have and are evaluating 64,000 over positive mothers from 30 countries and are evaluating 192 over studies. We need to develop bundles about the use of ECMO in pregnancy. We need to appreciate the second victims who are non-COVID but who still suffer from significant mortality and morbidity because our main focus has been COVID-19. We need to overcome the COVID stigma because you will hear stories of how the moment a pregnant mother has been diagnosed to be positive, her care de-escalates. She does not get the sufficient care, the sufficient attention that she needs. We need to reduce the stigma associated with COVID-19. We as a fraternity need to battle the pandemic of misinformation, which I believe is far more challenging than battling the pandemic and itself. We need to talk about the importance of vaccination of adolescent mothers. It's timely that we revisit the importance of boosters for healthcare givers and also for pregnant mothers. So, ladies and gentlemen, to summarize my talk, COVID-19 has significant maternal and fetal implications. 1 in 7 pregnant mothers needs ICU care, especially if it is related to the Delta virus. We need a multi-professional, sub-specialized team. It is important to have a shared decision-making, not just the intensivist, not just the physician, but please include the obstetrician and maternal fetal medicine specialists. Please remember the mother's life is the utmost priority. Do not withhold interventions in the name of pregnancy. It does not cause harm. It is often ignorance rather than science. Please remember that in pregnancy, you do need to have special considerations which are highlighted. Medications such as monoclonal antibodies, high-resolution CT scans, Tocilizumab are not contraindicated in pregnancy. You can turn a mother prone. You don't really need to prophylactically deliver someone. Ventilation alone is not an indication for delivery. There's only one criteria: deliver in most instances for obstetric indications. The long COVID, you need a sub-specialized care. And finally, ladies and gentlemen, we need to learn from each other. We need to work as a team. And I believe that is far more important with regards to improving outcomes of pregnant mothers. So with that, I would like to dedicate this talk and a special thanks to the wonderful team that I've privileged to work with in my hospital, the ID physician, the anesthetist, the neonatologist, the microbiologist, the radiologist. It has been a wonderful privilege to work with them. And with that, I would like to thank you for the attention, and I'll be more than happy to address each and any questions if you have. Thank you so much, ladies and gentlemen.